Today, welcome everyone on board. Actually, today I was just thinking to dissect our, um, you can say, academic as well as practical approach via group of patients. As you can see in this list that I have just tried to chalk out, it will just have a very good exercise because when we are not only being asked in the exam, but also practically when we are planning any anesthesia management, there are certain patient groups which we have. Okay, and so it's very easy if we already have a you can say plan in our mind. And, uh, so today we will just try to uh, learn through a different approach. So to start with pregnant patient. Okay, so like you will have a lot of scenarios in will it will this will be a point, a pregnant patient 35 weeks pregnant for that dash. Okay, so that problem can be obstetric or that can be non-obstetric, but whatever problem it is, there will be certain concerns which will be related to a patient having like a pregnancy. Okay. So in that case, of course, it will be depending on whether it's first trimester, second trimester, or third trimester. So it will be revolving around the physiological, pharmacological, and anatomical changes, which is leading to different approach in our anesthesia conduct. Okay, different approach in our anesthesia conduct. And what you should be looking at is you can say like you can put it in that way, that how will you be doing something which will be related to preoperative, intraoperative, and postoperative. Okay, and you will be assessing each and every step of anesthesia, like pre-medication, monitoring, induction, muscle relaxant, maintenance, analgesia, fluid therapy, recovery, and post-op course with all the groups, like not only this pregnant patient, all the groups. And this is just a practice that you will be looking at. Like I'm just giving you an example. We will go a little bit in detail, but my approach, my task, my target for this discussion is that you should have an approach like that. Okay, so like pre-medication in a pregnant patient will be, for example, acid prophylaxis. Okay, so this is one example. Monitoring, in addition to standard 1 and standard 2 monitoring, the patient can have CTG monitoring. Patient can have like we have to monitor the urine output with reference to fluid balance. So with reference to induction agent, because of rapid sequence induction, thiopentone is the best choice for rapid sequence induction. So similarly, muscle relaxant, all effects will be a little increased. Uh, uh, so like you can slightly reduce the doses. Okay. Similarly, MAC value will be decreased. Maintenance. So like I'm giving you an example. Analgesia. Certain options will be good for a pregnant patient. You will be avoiding medication which have teratogenic effects. So this is just an example. And this is another task that, for example, if you have given a certain data, because usually any table viva, they will be giving around, you can say, like I'm just giving you an example, 35 years, female, pregnant, okay, with the known case of myasthenia gravis for lab coli. Okay, so of course they will be asking further questions, but usually it total scenario will be 5 minutes. In that, they will be asking you about myasthenia gravis, pregnancy, and laparoscopic cholecystectomy. Okay, so you have to consider that they are going to ask all the yeah, or they are interested in listening from you. Such they need to evaluate whether you are safe in for pregnancy, you know about the problems in myasthenia gravis, and you know the critical steps of cholecystectomy. Okay, so it's very difficult to compile your answer unless you have prepared answer for pregnancy at least. Okay, and prepared answer for cholecystectomy. Of course, myasthenia gravis may be changed by sickle cell disease, may be changed by type 1 diabetes mellitus, may be changed by anything. But if you are able to have very compact, very precise answer for each condition, like 30 seconds to 1 minute answer, it will become very easy for you to answer the question. Okay. So, like for pregnant patient, like first of all, you just chalk in your mind that CNS, CVS, respiration, GIT, coagulation, like blood, okay, and renal, liver, all of them. Like whatever you are telling, there will be some changes, there will be some effect, and how to manage. Okay, so like because the people when they are asked this question or when they try to answer this question, unfortunately they do go in very haphazardly. But because like for example, I'm giving you example that as we told that because of effect of progesterone there is a soothing play and like hypnotic effect, so the mac values are decreased. So the change is in the because of progesterone there is decreased in mac, so you have to reduce the concentration. Okay, so this is the change effect and management. Similarly, for example, if you go here or respiratory and GIT will go a little together, that there is gastroparesis. Okay, gastroparesis, and there is engorgement of airway. Okay, there is enlarged breast tissue, and um, there is more oxygen consumption. Okay, number of effects are because of gravid uterus. Okay, uh, and sorry, FRC also, decrease in FRC. So if you combine these together, the effect, the reason is, for example, progesterone or gravid uterus. Okay, these are mainly two. There may be some other, but the net result is that easy desaturation, okay, difficult airway, and aspiration. So now you can chalk out that because of gastroparesis and difficult airway, increase oxygen consumption, decrease FRC, and like engorgement of airway. So now this patient is at risk of aspiration. This patient is having anticipated difficult airway. So what you should need to do now, immediately you can tell that's those things as well, that you will be doing pre-oxygenation, you will be doing rapid sequence or modified rapid sequence induction. You need to give acid prophylaxis. You need to anticipate difficult airway, and you need to do ramp position. Okay, rapid airway management position. So this answer will compile or cover all the problems related to respiratory system or GIT. Okay. So here, now, because my aim is to give you a hint, because I will be trying to touch a number of patient groups, and we will be just trying to cover as many as possible. Okay. Similarly, with the reference to CVS, so like CVS or blood, mainly there is like dilution anemia. Okay. So blood volume is increased, plasma volume is increased. Okay. Cardiac output is increased, heart rate is increased, stroke volume is increased. Okay. Uh, the coagulation, we can make it separately. So all result in, for example, like if you are giving, and there will be with reference to cesarean section, if it's like that. So just after delivery of the baby, the cardiac output will be at maximum. Okay. So what are the that you might need to control the medications, like because like volume of distribution will be, I think, increase if I'm not wrong. So you just need to be careful if you are giving too much fluid. You if you are not taking in consideration these factors, the patient can go in overload. Okay, you need to optimize the things accordingly. So and then of course the thing which you will never forget, that there are two lives. Okay, so whatever medication or whatever thing you are doing, you need to take care. Like you might need to have this left uterine tilt. Okay, you need to have obstetric team on board and have CTG pre-op, intra-op, and post-op. Okay, similarly, you need to counsel the or anticipate if maybe the patient can go into preterm labor or abortion. Okay, similarly, there may be teratogenicity. Okay, so these are the things which you need to consider with this reference. So similarly, with reference to increase coagulation factors, the patient is at risk of thromboembolism. So you need to embolize the patient. You need to avoid the stress. Might need to give some thromboprophylaxis, not only medical or non-medical. Okay. So like uh, by this way, these are basic points with reference to pregnancy. So of course, I'm not able to make, maybe I'm not able to recall each and every effect, but this is the thing should be in your mind. What are the changes? What is effect on the anesthesia management, and how will you anticipate or how will you manage? Okay, so that's few words about pregnancy or pregnant patient. So next, what is there? Okay, pediatric patient. So if you just think about pediatric patient, so pediatric patient will be similarly same anatomical, physiological, and pharmacological changes leading to anticipated challenges and problems in the anesthesia conduct. Okay, so few of them I will just tell. For example, consent issues. This is more so if you are appearing in the international exams, maybe in Pakistan or our part of world, maybe they are not asking a lot about it. This is one issue, consent issue. Then uh, preoperative anxiety. Okay, pre-op anxiolysis is a big challenge. Okay, then IV line, it's a big challenge. Pediatric IV line can embarrass any anesthetist anytime. Okay, then um, certain conditions which are prone, or certain procedures which will be prone for that thing. You need to have all the medication in a titrated way. Okay, titrated medications, diluted medications, uh, carefully calculation of doses. Okay, then equipment challenges, you need to prepare. Actually, these are why I'm telling them in pre-operative, because pre-operatively you need to calculate everything. You need to calculate the emergency dose medication doses. You need to have proper size endotracheal tube, proper size BP cuff, proper size maybe pulse oximeter. Normal pulse oximeter probe is not fit. You need to have the other one which is sticking at the nail bed. Okay, you might need to put it in the ear lobes or foot or anything like that. So like according to the age of the baby, the things will be a variety of things, but a number of things will be common. Temperature of the room, all the equipment, maybe bear hugger needed, organ this you need to have microburettes, you need to have syringe pumps or infusion pumps, optimal temperature in the room. So these are all things which you need to prepare before pushing the patient in the OR. Okay, then what else? That you will be anticipating difficult airway because of anterior larynx, because of short mouth, because of short trachea, because of easy desaturation, high oxygen consumption, not developed ventilatory mechanics, Okay. And so you will be anticipating. So there will be each and every step you need to know what to do, what to do. Like preoperative anxiolysis, you need to build up a repo. In international forums there is mock or model operation theaters where the for especially designed for kids, where they will be familiar to the oxygen mask, face mask. There are cherry or strawberry flavored. I have even seen myself there. So there are flavors, fragrance in the masks. So when you are doing the inhalation and induction, the baby is not crying sometimes. You might need to have amla cream. Amla cream will be giving anesthesia to the part, eutectic mixture of local anesthetic. Okay. So these are the different things you need to there should be because there are chances of drug errors or extra dose being given. Similarly, another thing is that you should be using smaller size syringes, like not 20 cc, 50 ml syringes. You should be using 3 ml or 5 ml. It's better to use because even a small amount of air going, and there will be better calculation of the doses. Okay. So these are the things with reference to like pediatric. Then less developed cardiovascular responses. Okay, heart rate dependent cardiac output. Similarly, high body surface area, high volume of distribution. Initial doses requirement will be more. Later on, you have to titrate the doses because of less developed kidneys and less developed liver. So there is a delay in metabolism and delay in excretion. High chances of hyponatremia. There are so many things which you can just think about it. Your answer should be in 30 seconds to 1 minute, all these things which I have told you. So again, when they are telling you the pediatric age group, you have to have challenging equipment, challenging monitoring, challenging IV lines, angiolosis, difficult airway, less developed responses. So you can make an answer, which if they are similar, as I told you for pregnant patient, there will be similar like 4 year or child going for adenotonsillectomy. So you need to tell about four concerns in a 4 year child and concerns related to adenotonsillectomy. They can add some disease as well. They can put sickle cell disease or Down syndrome or thalassemia or anything. They can put uh, anything in that scenario. So this will be because remember one thing, they will not be telling you, can you tell the changes in pregnancy? It's least likely to be asked in a postgraduate exam. What are the changes in pregnant patient or what are the changes in pediatric patient? They will be giving you a scenario and they will be asking this thing. Okay. Similarly, I missed both in pediatric patient or pregnant patient, there is difference in the resuscitation. Okay, different algorithms of BLS or ACLS in pregnant patient, which it includes a slightly higher up chest compression and left uterine tilt and delivery of the baby. If the resuscitation is not going nicely, within 4 to 5 minutes, delivery of the baby. These are three different things. Similarly, in pediatric, there is different algorithm. You know about it. So next, we will move on to elderly, I think. Elderly patient. Okay. So in elderly, similarly, like can now can someone help me in telling in the same way which I am telling for elderly patient? Who will tell? Asham, do you like to tell? Are you there, Hasham?
Sir, we have to decrease the dose of the drugs. Sir, can
So
you hear me, sir?
yes, those what?
Means, sir, for for NSAIDs, we have the concerns of the renal concerns. We have to decrease the dose, and there is a hypothermia in geriatric patients,
What else?
and like sir, decreased volume of distribution, and and difficult here means there is we cannot be able to anticipate difficult situation because of the rheumatoid arthritis. Like, can yes sir? Are you
Your voice is coming very distorted. So, like if I will just rephrase, you are telling about airway, you are telling about comorbidities, okay? Uh, IV lines,
yes sir? IV
positioning,
lines means
positioning,
positioning. Yes,
okay?
right sir, right sir.
Then cardiovascular system and respiratory system. In cardiovascular system, less again the same thing like in pediatric, less responsive, less responsive cardiovascular responses. Okay, like if you are giving the medications, you might need to give slowly, titrated doses, because if you give like that, maybe patient will have sudden hypotension, because normally the response of hypotension will be tachycardia and compensation. So here it will not respond in the way it should be. Okay. Similarly, in airway, not only difficult mask ventilation with reference to E. dentulus, there may be osteoarthritis of the joints. Okay. So positioning will be difficult. Airway, as I mentioned, that these are the things which you, if you try to manipulate the neck, you might need damage to cervical vertebrae. Like there are chances of osteoarthritis. So you need to position the patient carefully. There will be more chances of comorbidities. Okay. So diabetes mellitus or hypertension or ischemic heart disease or heart failure, there will be more chances. So what else? Anything else? Okay. So like induction, like if I just convert it to what I was trying to tell, that same thing you will be telling. There will be cardiac risk, pulmonary risk, renal risk, as you were saying. There will be chances of reduced GFR, okay, age-related decrease, or because of comorbidities. So if you are giving high dose of NSAIDs, this can precipitate. Similarly, like airway management, as I told, spatial monitoring, you might need to have arterial blood pressure monitoring uh, with reference to like careful tight monitoring of beat to beat blood pressure monitoring. If in case there is a exaggerated like response to anesthetic medications. So so similarly, like you should be thinking about remedication, monitoring, induction. If you remember, believe me, if you remember this thing and you fit the conditions in this chart, it will become very easy for you not to forget. But if you start haphazardly, it will be difficult. Okay. So elderly patient, you should be just thinking what are the things, more chances of delirium. Elderly
Deliriums.
patients are having cognitive dysfunction post-operative. It's a terminology, post-operative cognitive dysfunction. So the elderly patient will be at risk of having post-operative cognitive dysfunction. So so these are the like things you should be considering when you are uh, focusing on a elderly patient. Anemic patient. Okay. So if you are handling an anemic patient, what should be your concerns? Hasham, can you hear me? Are you not able to speak out? Yes, Ibrahim, you want to speak. Anyone wants to speak out, or should I continue myself? Anemic patient, what will be things in your consideration? Okay, so I think nobody's interested to speak out. Okay, so just a second, please. So, as in anemia, you know that there is decreased oxygen carrying capacity. Okay. So the response to anemia is usually in the form of tachycardia and increased blood volume. Okay. So this is making cardiac output may be increased. There will be tachycardia. So whenever there is tachycardia, there is increased oxygen demand. Okay. And decrease oxygen supply. So these are bad things. So similarly, according to the cause of anemia, there will be load. So whatever you are doing with reference to anesthesia medications, the exaggerated response will be there. Okay. So like heart, you are giving medications which are cardiac depressant, and heart is already under stress. So this can create this can create problem. Okay. Similarly, you don't have, like normally maybe you have allowable blood loss. Okay. Like you can, if you have, for example, good hemoglobin level preoperatively, so you can have more allowable blood loss. But here you might need to give blood transfusion because there is no margin. Okay. So of course it will be depending on uh, the cause. So anemia is a tip of iceberg because there will be some reason. There may be a liver problem, or there may be renal problem, or there may be a carcinoma, anything which is the cause of anemia. Okay, so so all these things should be in your mind. Yes, just a second. All these things should be in your mind when you are trying to uh, uh, like think about it. So you might need to arrange blood and blood products. You might need to have like things like cardiac output monitor. Okay, you might there is a specialized monitor in just like pulse oximeter, and it is giving like a constant hemoglobin level. Okay, you might need to do ABGs. So in anemic patient, these will be the thing. Of course, the reason of anemia, whether it is compensated or compensated, the concerns related to the cause of anemia, okay, and anesthetic conduct. So you will be thinking that this patient heart is at risk. Heart is at risk of developing some problems. So you might need to anticipate accordingly. Okay. Similarly, asthma, COPD, or any patient who are at prone to pulmonary complications. So how to reflect on it? That just a second. Okay. So actually, asthma or COPD or any restrictive lung disease or things like that, actually, for example, asthma, COPD, there is reactive airway. Okay. So reactive airway means you might need to anything which can irritate the airway. Okay. Like for example, if you are handling the airway in light plane of anesthesia, it's a it's a thing which can trigger bronchospasm. If there is anything which is increasing the secretions, so it can create problem. If you have any medication which is releasing histamine, it's a problem. Okay. So anything which can exaggerate, so this will be a challenge for you. Similarly, if you have a patient with COPD, you will try to correct the correctable component. You will be trying to correct the correctable to have target the correctable component, like by doing some nebulization, some steroids, some antibiotics, some positional strategies, incentive spirometry. You will be able to decrease the morbidity in a patient with COPD. Similarly, if albumin levels are low, so you can replace the albumin, because low albumin level is a risk factor for pulmonary complication with reference to more chances of pulmonary edema. Okay. There will be certain factors which you will be anticipating. Like for example, if a patient with the COPD is going for any surgery which is upper abdominal or thoracic, there will be chances of uh, this like reactivity, like there will be more chances of edema. So this is one of the thing. Like, so you can chalk out what anesthetic medication you will be avoiding, like morphine, like atracurium. Okay, like there is a controversial use of NSAIDs. Okay, so and you will be trying to have deep plane of anesthesia for airway manipulation. Like thiopentone, people are still using thio versus propofol. Okay, so propofol is a better choice. You can easily say that ketamine. Yes, ketamine has bronchodilatory effect, but it increases the secretions. So again, it's not 100% safe to use ketamine. Yes, in low dose, it will be very helpful because it will be a very good analgesic. It will have then another problem that ketamine does not blunt the airway reflexes. So you should be knowing about it. Then you will be using all the things which will blunt the airway reflexes, like you will be using lidocaine, you will be using good dose of opioids. Okay, so that will help you in avoiding the airway reflexes. Similarly, we don't use isoflurane or desflurane for induction, but they can exaggerate more problems. So sevoflurane will be a better choice. Okay, what else? You should have a baseline status with reference to like asthma or COPD, but is like because difference asthma patient, if without attack there is that's least likely that it will be exaggerated. But if it's a patient with frequent history and like you have there is some allergies, so you have to take care of it. Similarly, if you have a patient with COPD on steroids, so you have to take care that you have to replace the steroid. What you say is stress dose replacement, stress dose opioid. So if the patients are on chronic opioid use, chronic steroid use, you need to give the replacement. So this will be not only on COPD. There are so many conditions in which a patient can have any autoimmune disease. So these things which should be considering. Okay. Okay. There are like COPD in with the regional anesthesia, especially spinal, for example. Remember one thing that it's not absolutely safe to give spinal. Because if you have a COPD patient and you are giving spinal, still, if the patient is dependent on the like extra muscles, like abdominal muscles or intercostal muscles, okay, so if you give spinal and these muscles are blocked by spinal, actually it will create a big problem. Patient might not be able to lie on the bed. So if you are giving spinal or epidural, it's not absolutely safe. In the exam, when they are telling, when you are telling the answer, you should be taking care of it. And in all the conduct of anesthesia, you should be thinking what you are giving. For example, another thing which came to my mind is the patient is taking beta agonists. Okay, especially nebulization or any way oral, for example. This patient is at risk of hypokalemia. Okay, so you have to take care. You might need to give replacement, or it should be in your mind that if they are asking about asthma, so you should know that this patient is taking beta agonist. So another thing will be that patient will be having tachycardia it's because of salbutamol. So tachycardia and hypokalemia should be in your mind when you are handling a patient with asthma or COPD. Okay, so I hope um, you are understanding what I'm trying to deliver. Smoker. So almost the same things which we have discussed. There will be chances of bronchospasm. There will be chances of increased secretion. There is negative inotropic effect. There is of nicotine. Whenever you think about smoking, think about the extra things, but think about nicotine and carbon monoxide. Increased secretion, bronchospasm. So these are the things which are related to smoking. So you will be anticipating exaggerated airway responses in a smoker. Okay. And it's a pulmonary risk factor. You might need to give a lot of care when you are anesthetizing a smoker. Okay. So like this is a separate thing that what you will be doing. You will try to stop smoking. Even if you stop it for 24 hours, it will reduce the carbon monoxide level, it will reduce the nicotine level, and it will have some positive effects in your conduct of anesthesia. But ideally, it should be stopped 4 to 6 weeks. Okay. So you should know the chart that after one day, what will happen, after 1 week, what will happen, after 4 weeks, what will happen. So you should be knowing with the chronologically, like what will happen with reference to the duration of smoking cessation. Okay. If I'm missing something with reference to pulmonary, one thing I told you about airway reflexes, medications, anesthesia conduct. Um, Similarly, one thing was striking my mind, baseline function. Okay. So baseline function will be with reference to pulmonary function test. Okay. Or chest X-ray. So you need to be very careful about the preoperative status. Alcoholic patient, addict, and opioid dependent patient. So like actually, we had missed, we had not finished this alcoholic liver disease, but I was busy for the last 3 days. So maybe I will try to do it, but I was thinking to do it today. Alcoholic patient will have, it depends on acute alcoholism or chronic alcoholism, because the effects are a little bit different. If you have acute, then the MAC will be reduced. If you have a chronic, the MAC will be increased. Okay. Similarly, that like alcoholic patient will have liver problem. There may be anemia. There may be nutritional deficiencies. There are so many things which are related to it, but like alcoholic patient for anesthesia and withdrawal symptoms. Okay. If the patient has stopped recently, or there will be a duration in which the alcohol is suddenly stopped, there you can expect withdrawal symptoms. So aggressive behavior, exaggerated responses, more chances of postoperative cognitive dysfunction, delirium you can expect. So if you are dealing with any alcoholic patient, these are the things you should be thinking. It's almost similar effect will be any addiction. But with especially in these like there will be addiction with reference to opioids or any other addiction. In addition to all these patients can have withdrawal symptoms, just like alcoholism. Okay, so alcoholic patients sometimes are required to give thiamine postoperatively, or like you can expect management of delirium tremens. This is the like with reference to alcoholism. Similarly with opioid, so you have to opioid patient will be of two, three categories. Okay, one patient will be opioid, which is addict, already taking opioids. This is one category. One category will be which has stopped and not under treatment of withdrawal. And there is one patient who is on methadone or naltrexone. Okay. So these are three different categories of patients. Some of the things are common. If they are IV drug abuser, if you are taking IV, so there are chances of infection. So you can have occupational health hazards. That next patient will have more chances of hepatitis or any other communicable disease. There will be poor hygiene. Okay. There will be like these are the things which are related to these IV drug abusers. And so you have to take care of it. But other effects are according different medications will have different effect. Opioids, as I told you, that if the patient are on replacement, or on chronic opioid use, yes, another category is the patient which are receiving therapeutic opioids, like for cancer pain or any other intractable pain in which patients are receiving it as a therapeutic. So you have to anticipate accordingly. One thing will be that you should be knowing the interconversion of opioids. Okay, interconversion of opioids, and you will be replacing the opioids accordingly. Like for example, if patient is taking oral morphine, so you need to convert it into IV. Okay, you should be knowing how, like for example, if 10 milligram oral opioid patient is taking, so around you need to give one third, if I'm not wrong. You just need to recall, but I think it's one third for IV. If you are whatever the patient is taking, so you need to give 3 milligram IV or 10 milligram oral. Just reconfirm what I'm saying. So similarly, conversion between morphine and fentanyl, or morphine or methadone into morphine. So you should be knowing, I don't recall the chart, but you should be knowing the interconversion of opioid and IV versus oral conversion. These are two charts. Maybe you will find in articles, or you will find in, I will try to share with you. So these are the things which should be knowing. You have to replace whatever opioids a patient is taking. Equipotent doses of opioids you have to replace, and of course extra opioids with reference to the pain. Okay. So these are the things you should be knowing. Another thing which you can face in these patients is opioid induced hyperalgesia. Opioid induced hyperalgesia. So this patient might need require more opioids than normal. Okay. So these are some concern with reference to um, drug addict or like opioids. Similarly, uh, bleeding patient. Okay. Bleeding patient. If a patient is bleeding, I actually, one will be anticipated bleeding, and one is, a number of things are related to anemia. But especially if you have a bleeding patient, whether it is upper GI bleed, lower GI bleed, hemoptysis, or through a firearm, or through a stab wound, or anything, okay, or a surgical bleed, there are so many things which are common. Okay, you should be, I will be just refer just a second, please. Some of the thing you should be knowing. One word you might need to say is MTP, massive transfusion protocol. So this is one thing you should be knowing. Then another different word will be cell saver. Okay. Then another thing uh, will be that like anti like rep massive blood transfusion and complications related to it. Okay. This is another thing. I will just try to tell you some words. Then similarly, like uh, you might need to have this large bore IV cannulas. Okay. Then you might need to have blood warmer. Then rapid infuser system, level one infuser. Okay. Then estimation of blood loss. So estimation of blood loss in a bleeding patient is very important. So you might need to have some like subjective assessment and some objective assessment, and also what is the, because whenever you are having massive blood transfusion, this patient is at risk of coagulopathy. This patient is at risk of post transfusion complications, a lot of complications like in the trolley, infections, immediate reaction, minor reactions, like ABO incompatibility, RH incompatibility. So you should be anticipating all the electrolyte problems, the hypothermia. Uh, so like you should be anticipating all these things in these patients. So cell saver will help in replacing the hematocrit. Okay, but it will not be able to replace the coagulation factors or platelets. So cell saver is a closed system in which blood is taken, cleaned, and retransfuse the RBCs. And there is a mechanism by which you can concentrate according to the requirement. Okay. But remember, but hematocrit cell saver will not replace the coagulation factors. Similarly, like large bore IV cannulas and massive transfusion protocol actually is a hospital-based protocol in which when you activate it, uncross match blood will come, blood and blood products, with PRBCs, FFPs, precipitate according to the need. Okay. And it will be either O negative or O positive. O negative for blood bearing females, and usually O positive for others. And similarly, there will be something else which you can ask you is recombinant factor 7. This will also come in, should be in your answer. Then other medication will be tranexamic acid. Okay. There will be some, like there will be some other things which you can tell. Hypotensive anesthesia, not in all cases, but this should be in your mind. Hypotensive anesthesia. Then anything which is avoiding the sympathetic uh, over sympathetic stimulation. Okay. Then positional strategies. Positional strategies. I'm telling you, this is not in all use of tourniquet. Okay. So there will be some surgical maneuvers, there will be some anesthetic maneuvers, there will be some uh, like uh, uh,
أكيد يا
I
أخي.
think, sorry. Okay. So in a bleeding patient, that's what which I can, and yes, another thing is monitoring. So monitoring will be one through ABGs. Other thing, because there will be some complication following it. So thromboelastography or rotum. Okay. Bedside hemoq, as I told you, that there is a option of a monitor which is giving the rough estimate of hemoglobin. Okay. Or rapid assessment of CBC and everything. So similarly, whenever you have massive blood transfusion, also you might need to have this FDPs and fibrinogen levels. Okay. So because this patient is at risk of D-dimers, uh, these patients are at risk of going into DIC. So you will be monitoring through these things. These are like some of the things which you should be needing uh, when you are anticipating a bleeding patient. Well, we will just do one more and then we will finish for today. Just a second. Because actually this is a slightly longer, so I think we will continue from here. Any questions? Anyone wants to ask any question before I finish? Okay, so thanks a lot, all of you, for your presence, and we will, like I close the sharing. So I'm just because remember one thing. I know that in this sort of way of learning is a little atypical. But I tell you something, if you just read now at this time, especially the people who are going for exam, about pregnant patient, pediatric patient, elderly patient, actually some of the things I missed in pediatric, of I am not able to tell each and everything. But when they are asking you and suddenly this group is coming, you can just make your answer with these points. Okay. So that was my aim. So tomorrow, inshallah, we will just try to have embolism, uh, difficult airway, and positioning. Okay. So uh, we will continue for here. Okay. So thank you very much. See you tomorrow, inshallah.